All right, folks, I might just get us started. I think we had a couple of people still joining us, but I can get us kicked off. I know we'll have about an hour and a half together today and want to leave room for plenty of discussion. And I know that some of our project team might have to drop off at the hour. And so I want to give as much time to be able to ask them questions as possible too. So we'll get kicked off here. Thank you all so much for joining. This is our first TA session for Stanislaus and San Joaquin County CBOs. And we're so excited to be able to get to meet some of you all today and have this kind of intimate TA session with all of you. Wanted to just give you a little bit of background about ourselves and the project as we get started. For folks that might not be familiar, first of all, my name is Sadhana Devaraja. I'm managing director here at HealthBegins. We are the project lead on this TA effort related to CalAIM and managed care plan CBO partnerships. We are joined by Aurrera Health Group, who's our project partner on this project. And we've got some of our folks on the line here, both Lucy and Jill, who can jump in and help with questions as they come up. This work is generously funded by the California Healthcare Foundation, without which this would not be possible. And I'm going to jump right in. Just here are some key terms for us to level set on. We're not going to spend much time on key terms. I'm not sure if folks have joined us for previous sessions, for regional sessions or for statewide sessions, but what we're doing here is not really level setting on these terms during these sessions, but we're assuming that folks know these acronyms and are looking to partner within the context of CalAIM. So hoping these are familiar to you. If we take a look at the objectives for this session, what we're really trying to do is to, one, describe what this TA effort is, this CalAIM Medi-Cal CBO Partnership Network that we're developing, and to understand, for the CBOs in the room, to understand who your partner MCP contacts are and how to best contact them. That'll be a key part of today. And I'm so grateful to have our plan partners here in the room to be able to either start or continue the relationships that you have with them. We want to spend the bulk of our time today really describing key contracting considerations for CBOs, really in the context of community supports within CalAIM. And so that's going to be a key part of the presentation today. And then we will touch on some of the approaches to estimating costs and revenues, especially within the context of housing-related community supports. We have a tool there that we can share with you. And so kind of flowing from that, this is our agenda for today. I'll spend a little bit of time on the background and objectives as I did, and then go into the plan contacts and context in San Joaquin and Stanislaus, talk about key contracting considerations. We'll have a Q&A period after that, and then move on to some payment and budgeting considerations before we close out. Please feel free to use the chat during this session. We engage with the chat often. We have a lot of folks who can help raise up any questions that are coming up. Our implementation partners, as well as our plan partners, will take a stab at answering them if possible. And if not, we'll also be able to collate all of the questions and take them offline to answer if that's the more appropriate venue for them. So please share questions in the chat. It's helpful for your peer CBOs to see. It's helpful for all of the subject matter experts and plan experts to be able to see them. And we'll address as much as we can today during the session. In the meantime, just to check that folks are comfortable with chat, if you could chat in your name and your organization to get us started, it would be great and really helpful for us to see where folks are coming from today. And while people do that, it would be really helpful to get introductions from the folks in the room that are with plans. And so maybe I'll turn it over. I saw Cynthia in the room. I don't know, Cynthia, you want to go first from Health Plan of San Joaquin to just tell us who you are?
Sure. Good afternoon, everyone. My name is Cynthia Pena, and I'm the Director of Special Projects at the Health Plan of San Joaquin. And I am working on the ECM and Community Supports implementation under really covering the ops area. You're probably familiar with Jeanette Lucht, who's also the Director of Special Projects. Unfortunately, she couldn't make it here, but she and I are both partnering on this implementation together. So thank you so much, and we welcome any questions from our partners.
Thank you so much, Cynthia. And then on the HealthNet side, maybe I will turn it to Nye to kick us off here.
Great, thank you so much. Hi, good afternoon, everyone. And I just want to say thank you so much for participating on today's call. I'm hoping that it's going to be very informative. My name is Nye Kasich. I'm from HealthNet. I'm Vice President of Medi-Cal Regional Lead in San Joaquin and Stanislaus County. And I'm hoping that this will give an opportunity for folks to have further information and for us to connect. I'm going to pass the ball over to my colleague, Nancy, who's on the call as well.
Hi, and my apologies, I'm off camera. I'll be driving for most of this call. I'm Nancy Wang-Deepak-Kalev, Senior Director of Systems of Care at HealthNet, and one of my responsibilities area is for community supports implementation statewide. Thank you and welcome.
Thank you all so much, and thank you for being a part of this effort and for helping bring some CBOs into the room, and also for being available for this session today. So we're really looking forward to the discussion that comes from this. Just to give folks background on this project, if you haven't been on any of our previous sessions, you know, we've this is really an effort that we started, as I mentioned, backed by the California Healthcare Foundation to help realize the promise of CalAIM. And so we've really landed on this effort as a way to help support CBOs as you're embarking on these partnerships with Medi-Cal managed care plans, and to really support the kind of knowledge building, the capacity building, and learning what needs to happen to be part of CalAIM. And so this is the first of 2 county-specific sessions that we're doing as part of this work. So far, we've had a regional session that has brought CBOs from all 4 of the counties that you see on screen together. We have had a statewide session last week that was open to all CBOs, and today's is the first of the San Joaquin Stanislaus sessions. We'll have another one later this year. And so we're really thrilled to have you all as part of this. Our county-specific sessions are by nature pretty intimate. You know, we were targeting around 8 to 10 CBOs, and really hoping that we can have some good discussion as a result of kind of that smaller group. Just to refresh folks on the value proposition that we're seeing here, we're, you know, hoping we can support CBOs through this TA effort, and really build up skills in these ways to describe components of CalAIM, to assess your strengths, to develop knowledge and skills, really to strengthen relationships between the CBOs and managed care plans, as well as others in your provider network, and eventually, you know, draft a plan, think through a plan that your organization can take or develop to strengthen these relationships, kind of understand where to go from here. And similarly, you know, we have value propositions through this work for managed care plans, and they're kind of on the flip side of the coin. So to assess readiness of CBOs to engage in this work, strengthen relationships, understand provider capacity, those types of things. So we're hoping that this TA provision will be mutually beneficial while we are really tailoring it for CBOs. So we, in terms of who's in the room, and thank you for, you know, jumping in chat and saying your names and your organizations. We're really thrilled to see such a diverse group here. We're assuming that folks are all representing San Joaquin or Stanislaus serving CBOs, and that you're planning to provide community support services through CalAIM, that you're familiar with CalAIM and community supports, at least at a high level, as I mentioned previously, and that you're interested in partnering or building or strengthening relationships with the managed care plans in your service area. And so to just get a sense for folks in the room, I'm wondering if you can respond to this poll. And I'm not sure if Nasra, you have the ability to launch this poll. There you go. If you could just take a second to answer, which of the following community supports is your CBO hoping to provide? And I see a couple folks have responded. We do have unsure. If you're not sure, between these definitions, between the terms, feel free to put in don't know as a possibility as well. And I'll leave it open just for a couple more seconds here. I'll do a countdown here of 5, 4, 3, 2, 1. And so if we can end the poll and then share results, folks will see that most of the people in the room, most of the CBOs in the room are looking at housing related community supports, which is actually no, most folks are looking at medically tailored meals in this room, and then housing related supports as a second here. And then it looks like some recuperative care, asthma remediation, and other. So thank you all for jumping in on that. And then for poll number 2, wondering how far you are along in contracting process. So if we can launch that one. And my understanding is that, some of you might be in multiple counties, you might be in kind of multiple service areas. And so it's just helpful to know kind of across the board where you might be. Okay. See a good group of folks responding, and I'll close it out in 5, 4, 3, 2, 1. If we could close it and then share results. So it looks like an interesting division between just kind of starting conversations, and then some folks are in contract negotiations. It's really fascinating. So looks like we'll have a great discussion, and we really, like I said before, encourage you to use chat for your questions. I think there's a lot of benefit in terms of being in this mixed room for folks to learn from each other. So really, really glad to see that diversity. And so we wanted to just, start off by talking through who CBOs can contact in Stanislaus and San Joaquin County. And also, just let folks from the plans, if you would like to, weigh in at all on what plan specific information or context that you think would be helpful for CBOs to know. I know that as we were gearing up for today's call, something that we heard from both Healthnet and from the Health Plan of San Joaquin as an objective was to make sure that CBOs felt supported through this process. I appreciated the recognition from both plans about how daunting this might seem, especially as we launch into a conversation about contracting standard terms and conditions and kind of what variation might exist. And so just wanted to open up the space for, and maybe we'll do Healthnet first here. Nai, if you'd just like to, mention what's the best way to contact Healthnet and any other kind of words of support that you think would be helpful for CBOs.
Yeah, and I think we do have a Healthnet email address, which is the one that's listed, ECM_ILS@healthnet.com, excuse me. for both San Joaquin and Stanislaus County. And then I think for folks who are interested in contacting us directly, I'm more than happy to include my email address in the chat. So if they wanted to reach out to either myself or one of my team members, Anna Hernandez, I'll go ahead and put that in right now.
Thank you so much, Nye. And then Cynthia, I'll ask you to do the same.
Yes, and I would really resonate with your comment. So I would say definitely we want to support all of our CBOs and really ensure that this is a guided process for them, and ensure that, you know, we ease the implementation as much as we can. We have been in discussions regarding various topics. So I think, you know, our CBOs have, you know, met our contacts from our oversight team, our contracting team, and our, you know, soon to be our provider services team, which will really be in charge of the relationship going forward. So I can share those contacts afterward. And then of course, you can also always reach out to myself. I can share my email address as well as Jeanette Lucht, and we will definitely help direct our providers to any question or any help that they need along the way.
Thank you, Cynthia. Thank you both. I think that you all heard it from both of them here. Please enter your questions in chat. Feel free to reach out directly to any of the individuals that have put their emails in chat. We'll also collate them for the follow-up email, so you have all of those emails in one place. But really wanted to make sure we were kicking off with that that framing and that invitation to all of you. So, you know, what we are framing up here today is to help everyone speak the same language related to contract terms. So, you know, we think it's helpful for CBOs to familiarize yourself with the definitions and standard contract terms as a baseline for your conversations with the plans. And of course, plans may have variations from the definitions and standard contract terms, which we'll be going into a little bit today. And it's going to be really important for you to, you know, have those direct contacts with your plan partner to understand where those variations are really showing up from the templated material for what is going to affect you. And so these are the standard terms and conditions as they show up in the DHCS standard terms and conditions. And here are the ones that we're going to focus on in the immediate term. So before I turn it to our next speaker, I just wanted to ask kind of one last poll question, which is how many different, and maybe we can launch this poll, it might not be up yet, but how many different CalAIM community support contracts do you anticipate engaging in within the next year? And so I think the poll just launched here. And I see folks are responding. This will be a good kind of baseline as we get into the conversation here today. And I will close this out in 5, 4, 3, 2, 1. So if we could end the poll and then share the results, it looks like there are kind of equal amounts of folks that don't know or will be looking at 3 or more contracts. And then we do have one CBO with 1 contract in the horizon. So that's great to know kind of what we're looking at here. So thank you for those responses. And I'm going to turn it over to our colleague, Lisa Chan-Sawen from Transform Health. You do a great job with this. Thank you so much, Lisa, for joining us today and for really making these contracting considerations so understandable and inviting. So I will turn it over to you for this this part of the presentation.
Can everybody hear me? Okay.
Yes, I can hear you.
Great. It's really a pleasure to be here with you all today. My name is Lisa Chan-Sawen. I'm the CEO and founder of Transform Health. We're a national women and minority-owned consulting firm operating in the healthcare systems transformation space. So we have the the privilege of supporting the city of Sacramento in their whole person care pilot. And I'm really excited to be here with you all today to share some thoughts, contracting considerations, things you guys should be thinking about as you move into the next step and look at, embarking as an ECM or community support provider. So thank you all for having me. Let's get into the meat of the conversation. And we're a small group, so please ask questions either in the chat, or if you want to raise your hand or speak verbally, please do. I think we're a small enough group that I'm happy to take some questions along the way. All right. So we wanted to first start off with the standard terms and conditions, as Sadhana had mentioned. These are standardized terms and conditions that are a core set of requirements that every single ECM community support contract must have. And so we wanted to make sure everybody was aware of what these standard terms and conditions are. You should expect to see very similar items in your contracts that you're receiving from Medi-Cal managed care plan partners. And what it does is it outlines a base set of requirements that all community support providers must adhere to. And so that document can be found online at that link that we've provided. And the way this document is linked to the Medi-Cal managed care plan contract is those standard terms and conditions must be also included in your Medi-Cal managed care plan contract. And so think of it as a floor where, the state is setting some baseline expectations of how all ECM CS contracts and programs should run across the state. And so that's the DHCS standard terms and conditions, that's the floor. And then on top of that are the provisions and terms in your Medi-Cal managed care contracts. Plans can have additional requirements in their programs or clarification of expectations. And so this is one of the reasons why you want to know both what is standard and then what are specific requirements related to the way you interact with that specific plan for that specific county. So a couple of things to really take into account as you're reviewing these contracts. Next slide, please. So, and thank you, Sana, for popping in the link to the standard terms and conditions in the chat. So for folks who are interested, you'll get the deck as well. But if you want to grab that link, now's a good time. So I wanted to walk everybody through what are the state's expectations in terms of service delivery. And so as we think about these service delivery requirements, I'm going to walk everybody through this. We'll talk through them. The state does expect every community support provider to deliver contracted community supports in accordance with the state's service definitions and requirements. And so, one thing I'll flag for everybody is you want to know what the state expects in terms of these service definitions and requirements. Those are spelled out in the state's program guides. And under ECM, there's an ECM program guide, as well as for community supports, has a separate program guide. That program guide will be very useful because that sets the baseline across the state. And plans may also issue their own plan-specific program guides for you to follow as you build your programs and begin implementing and providing community support services. So you want to pay attention to those guides. In addition, the standard terms and condition requires that all community support providers maintain staffing that allows for timely, high quality service delivery that it is contracted to provide. And so you want to, knowing that this is a standard term and condition in your plan contract, you want to pay attention if there are other requirements in terms of meeting the state requirement. So you want to think about what it means in terms of your staffing, Is there a specific staffing ratio that the plan may want you to adhere to? Are there specific training requirements? Is there expertise that the plan expects your staff to maintain as part of its credentials in terms of being able to deliver these community supports? So you want to pay attention to what those requirements are, and there may be some additional expectations, requirements, depending on the plan, and those will be most likely spelled out in your plan contract or in your plan program guide. In addition, so those are sort of like at a high level, but when we think about what the actual work looks like, the state expects that community support providers will be able to receive, accept, and act upon referrals from the plan for authorized community supports. So you'll want to think about, how our referrals are going to be made and accepted. Is there a process that your health plan wants you to use? And are there any workflows that you want to build internally to make sure that you can accept and act upon the referrals that you receive? Because, when we look at C2 and 3, the expectation is once you get that referral, as a community support provider, you'll be conducting outreach to that referred beneficiary as soon as possible, including making a best effort to conduct initial outreach within 24 hours of assignment, if it's applicable. Some of the reasons for this is because depending on the population of focus, they may become harder and harder to reach the longer that you wait. And so when you have a warm handoff and a warm referral, in some instances, you'll be able to reach that individual quicker. For example, if they're homeless and they are unsheltered, they may be moving from one location to another. And so if you don't act quickly, you may lose contact and lose touch with that individual. You'll also be expected to be responsive to incoming calls or outreach from members, including maintaining a phone line. And so you want to think through, do you have the systems and processes in place within your organization to be able to accept and begin initiating services upon receiving those referrals? You'll also want to think through under C4, how you'll coordinate with other providers on that same beneficiary's care team in terms of service provision. So these are things like maybe you are a homeless services provider providing housing navigation services. And so you may need to connect with your ECM provider who's really thinking through the entire overarching care plan for that individual and take into account, well, this person, we have a voucher in hand, we may be able to move this person into a new placement, but in doing so, are you interrupting any other services in care? Do they have a specialty care appointment, for example, that may interact with their ability to engage and move into a new housing placement? Some of those conversations and coordinations will happen in conversation with other providers on that beneficiary's care team. And so as community support providers, you want to know who your ECM provider is for that beneficiary and really think about your service in coordination with everything else that's happening with that beneficiary, because you may find that there are certain times of the week, certain times of the day, methods of reaching individuals and engaging with other providers, touching, serving the same beneficiary will oftentimes yield information that will be actionable in terms of how you provide that service. So something to pay attention to. And you'll want to see if you have an existing process that can be reconfigured or that needs to be established. Some strategies for how to do this level of coordination is through huddles and teamlets, or even sharing of the care plans. You know, it can be as simple as picking up the phone. It can be a much more coordinated structure depending on the complexity of that individual patient's needs. So those are some of the structures you want to think about. And in terms of the delivery of the service, there may be cultural competency, linguistic requirements, non-discrimination requirements. All of these items will be outlined either in your plan contract or in your program guides. And so you want to pay attention to both and make sure that you're clear on what those expectations are. Next slide.
Yeah, and as I switch slide here, Lisa, I'm really curious from folks in the room, you know, if this is resonating in terms of the considerations that you have been considering. I know we had that split in terms of folks in the room that are just starting negotiations versus in process of contracting, at least among respondents, and would love to see via chat or otherwise, you know, how are these considerations coming up for you, either as you've possibly resolved them or as you're considering them in your early conversations. So just invite folks to use chat for that.
Absolutely. And we'll tailor the conversation based on your experiences and where you are in the process. So don't be shy about asking your questions so that, you know, we can all benefit and learn, even if we're at a different stage in the process. Thank you for that, Sadhna. So I wanted to also flag a couple of additional delivery service delivery requirements that are part of the special terms and conditions. Under D, you'll see here that there is an expectation that community support providers can obtain and document both consents and prior authorizations, as well as manage, share, and protect protected health information, or PHI. And so, you know, that's an important consideration, especially when we think about sort of the intersection between healthcare and social services. The reason why we pay extra attention to this is because under healthcare, the standard is HIPAA, which is a higher bar than what is typically required in consumer privacy protection laws. And so oftentimes, and we see this in quite a few instances, for example, the HMIS is built off of consumer protection laws, and that is the standard that is adhered to. But within healthcare, and since this is a Medi-Cal funded program, we have to adhere to HIPAA, which is a higher standard. And so you want to look at your existing processes and consider, do you have a process to store, share, and manage protected health information? And that information can come in the form of patient records, consents, authorizations. And so if you don't have a process or your standard is not HIPAA, then you'll want to look at your process and see what needs to be put in place to protect this information and ensure that you're sharing it in a safe way with all of your other provider partners. So it's a key thing to take into account. Especially when you consider that CS providers will be reimbursed only for services that are authorized by a Medi-Cal managed care plan. And yet you as a community support provider, there is an opportunity for you to make referrals back in. And so this comes into play when we think about the other box on this page, F, where community support providers are encouraged to identify any additional community supports members may benefit from and send these requests for community supports to the plan for authorization. You'll have an opportunity to conduct in-reach and identify other potential clients that may be eligible for ECM or community supports, and you may want to make referrals of those individuals back to the plans. And so, you know, you'll want to be thoughtful in terms of, as you send in those referrals, have they been authorized by the plan? Because if they are not authorized, you may be providing services that you won't be reimbursed from. So you'll want to have a workflow that takes in those pieces into account and allows you to also support individual clients who are transitioning out of community supports in the ECM program to support their transition planning too. So there's a couple of things here that are embedded that you may really want to think about, because you'll want to have the systems in place that not only protect the patient, but also protects your organization as well.
That's great.
It looks like there is a question from Virginia about HMIS. We store all of our data in the platform. How can we streamline this with a new platform? That may be an issue for us here at the shelter. Do you have a platform that the MCPs use? That's a great question, Virginia, and something that I know a lot of counties are currently dealing with. So there is a way to streamline this data. I think the big question though is, how is the HMIS platform utilized, and does it allow you to capture and share information with your health plan in a way that makes sense? And so, and this may look a little bit different in Stanislaus than in San Joaquin, because San Joaquin has a local health information exchange that may help connect HMIS with other local systems and facilitate that data exchange. If you're in a county where you don't have a local exchange, you may need to have conversations with your plan and potentially with your county in case those exchanges are being built, and you're looking at having a short-term solution until that solution is built, or if you're building a solution for the long term. HMIS platforms are not all built the same. There are different functions that counties can buy up on, but you really need to drill down in terms of what's happening and how your specific system looks like. I'll also add that most HMIS systems are not built for HIPAA, and that could potentially be challenging for your local COC. So you want to have conversations early on. I hope that is helpful, and I'm happy to talk further offline about specific considerations.
Thanks
All
for
right,
that, Lisa. And I'll also see if any of the other folks on our implementation team, or if any of the plans wanted to weigh in on that question. Just pause for a second to see if folks wanted to answer that.
Yeah, this is Jill. I think Lisa's answer is completely right. And the only thing I would add is that there are a lot of plans who have gained access to HMIS in recent years. So there may be some ability to share directly, through that mechanism, through identifying which clients are enrolled and having the plan look those clients up with their access. But that is unlikely to meet all of the reporting requirements that will be required under community support. So there will need to be another mechanism for producing reports.
To piggyback on what Jill shared, some plans are also providing electronic platform for some of their partners. So you want to, have conversations with your plan partners early on to understand what they have available to support your ability to provide these services, or if they're building something that could be useful that you should be taking into account as you're building their program.
Hi, this is Nancy from HealthNet. I can share with you, we are looking county by county on what would be sort of appropriate CIEs or community information exchanges, and then at minimal, sort of looking at what social care platforms that we can stand up, at least for the referral and authorization process. And right now, statewide, we're using the Find Help or Aunt Bertha platform that will be providing access to all of our community supports and ECM providers, but particularly for the community supports providers. They'll be able to receive referrals, be able to submit for authorization and payment and get the data, so the data piece will be there through Find Help. So we'll make that available for all of our contracted providers.
That's great. Thank you, Jill. Thank you, Nancy. And thank you, Virginia, for the question. So I can go to the next slide if that's.
All right, so let's spend a moment talking about data sharing, quality, and oversight. I know we talked a little bit about this already, but data sharing is going to be really important as part of your community supports programming. And so, plans are expected to ensure that you have access to demographic and administrative information that helps confirm your client's eligibility for the requested service. They'll want to ensure that you have appropriate administrative, clinical, and social service information. What I had mentioned earlier about the huddles and making sure that you're having information to make choices around timing and the provision of these services. You'll want to be able to capture and take that into account in order to effectively provide the requested services. And the third tranche is really around billing information needed to support your ability to provide and submit invoices. There is an expectation that, as a community support providers, that you're capturing touches, encounters, engagement attempts with the identified beneficiary. But, beyond that, you'll also want to think through, like, do you have a billing system that takes into account the different fiscal models? And for example, some of you had indicated that you may be engaging with multiple plan contracts over the course of the next year. We working in Sacramento, where we have 5 health plans, not all of our health plan partners are using, for example, the same fiscal and payment model. And so for the exact same services, we've had a provider share with us that they have one plan paying a fee-for-service payment and another plan paying per diem for the exact same service. So you'll want to consider and think about, are you in that situation? Because if you are, you'll want to ensure your billing process takes into account that variation. And maybe you're not. Maybe you're, all the plans are using the same billing mechanism. And so you can, really streamline your approach. So think about that. Think about what the plan's expectations are and their process for sharing data. If you're working with more than one plan, do their processes differ? If they do, you'll want to take that into account. The other thing I want to flag is there is an expectation that the plans will periodically conduct oversight and monitoring. And so they'll need your help in terms of reporting for audits and any corrective action. So the data exchange goes both ways. And so you'll want to consider, do you have any existing processes or systems that support your ability to conduct quality and oversight activities, to be able to support some of this reporting? And if you do not, what do you need to put in place to be able to do this so that you are ready when you receive these requests from your plan partners? Not seeing any questions. Let's talk about variations. So I had mentioned a little bit about variations in your contracts. And that's one of the reasons why we wanted to go through both the standard terms and conditions that all contracts should have, and then talk about some areas where variations can occur. And so, there's several things that you might want to watch for. We had already mentioned the staffing ratios and staffing requirements. Are they training and certification or licensure requirements? Any staffing ratios, things like that. We also talked a little bit about payment models. how are you going to be paid for the community supports that you're being contracted for? You may need to adjust your program model and your budget if you're being paid a fee-for-service model under a fee-for-service model, or a case rate, or a flat monthly rate per beneficiary per client assigned, which in healthcare we call a PMPM, a per member per month. So if you are in a PMPM model, you'll want to think through assignment of patients. How many patients can your organization expect to be assigned? If you're currently a whole person care provider, will you be keeping the current patients that you're serving? And then also think about duration of case. So for each of these patients that you're being assigned, how long can you expect to be serving each patient? What is that length of service before that community support may need to be reauthorized? Because that's going to help you really understand and think through how to budget and staff. We had mentioned receiving and providing referrals. You want to pay attention to what that process looks like, how frequently you may expect to receive referred patients. And if you have a potentially eligible client that you're already working with that you think meets the eligibility criteria of the ECMCS programs, what is that process for your organization to make a referral back to your plan partner? Some things to really take into account, because you may want to have a specific workflow, you may want to train your staff or adjust current processes to make sure that you can meet these requirements. And lastly, I'll just land data sharing, invoicing, and reporting requirements. Do you have the systems that support your ability to share data regularly with your plan partner, with other providers? Do you have systems that allow you to invoice your plans monthly and report data back to them on a regular basis? Or do you need to put in a solution? And is that solution short-term because there's a longer-term solution being developed by the plan or the county? Or do you want to go straight to a longer-term solution that you want to put into place? So these are some of the things that we hope that will be helpful as you're reviewing plan contracts, as things are coming up, and as you're developing your programming for next year. So with that, I'd like to open it up for questions.
I think I'll pull down the screen here just so I could see folks a little bit. And yeah, we would love to take any questions at this point on any of the material that Lisa presented. Wondering if these standard terms and conditions are resonating for folks. Pause here.
I had a follow-up question if I can. Hi, everybody. And Lisa, thank you so much as always for your partnership and presentation as well. That was awesome. I wanted to ask if I could follow up on Virginia's great question, and I think what Lisa you answered, and it sounds like Nancy also answered. It occurs to me that Virginia, that when you asked that question about the data that you're storing on that HMIS platform, that others who are maybe in the medically tailored meal space also have similar questions. And I'm just curious if those who are in the medically tailored meal space also have similar questions about the platforms that might be available to help support. So curious what platforms, any questions about the platforms that that you might be able to use, or you're hoping to be able to use to be able to support your delivery of community support services. And we have several folks from GA Foods and Mom's Meals, et cetera. I'm just curious if you had any similar questions about platforms or any of the topics that Lisa spoke about. Sounds like a quiet group. Can I turn one other question, and so I'll turn it back to you after I ask this next one. I think HealthNet provided a little bit of information about the, thanks Ken, thanks for your chat, I appreciate that. Nancy described the use of Aunt Bertha, for example, as a platform to help support information sharing and referrals. And I'm wondering, both on the HealthNet side as well as Cynthia on the Health Plan of San Joaquin side, there are platforms that the plans are using, and if you could speak especially on the Health Plan of San Joaquin side, are there any preferred platforms that you're also seeing or trying to help scale up to support platforms? And then a related question is, some of the referrals are going to be coming in not just from the plans, but from ECM providers. And I'm wondering if either of our plan partners or the broader team, Lisa, including you and Lucy and Jill, want to speak to any particularities to consider when it's about receiving referrals from ECM providers and not just information from the plans.
Sure, and I'll help with that discussion. So in receiving referrals from ECM providers, we would, sort of in the short term leverage our existing processes, which would involve our provider portal. In terms of the platforms, we are currently exploring, all three for a longer term solution as well.
And Rishi, if I could also add from HealthNet's perspective, I know Nancy spoke about Aunt Bertha, but I think for both Stanislaus and San Joaquin County, HealthNet has not made a determination, partially because we want to partner with Health Plan of San Joaquin and align with whatever decision they're considering. And we've been talking about also engaging the community, the providers or the provider network to get their input so that the system that we use is one and universal. Again, we want to ensure that this is going to be a smooth process to be able to place those referrals. And then, again, this is like, long-term goal, which is to ensure that we can receive billing directly from the community support service provider so that they can be paid timely. So there's a lot of work ahead here in this area, but I just wanted to share from HealthNet's perspective that no decision's been made for both counties. Our intent is, and our approach is to work with our plan partner and the community at large to make sure that whatever platform is identified, it's one that's going to be used and supported by all parties.
And this is Nancy from HealthNet. So just to add to that, our approach is really not to mandate or require a use of any particular platform. So we will have all routes of referral submissions, right? So our HealthNet provider portal will be accessible to all of our providers. We'll have a way to fax, to email, to call member services, provider services. So there'll be a sort of a no wrong door approach for submission. It just helps to streamline if we have an automated, platform process. But I do want to just, clarify for Find Help Aunt Bertha, that will be available to all counties statewide. We are looking, and as a baseline, right? And that's an opt-in. It's up to the providers to choose, but that will be available. We're trying to customize where there's some counties that are maybe using a community information exchange, right? Like San Diego uses San Diego 211 CIE, and that's really the main platform. So we're going to be using that for San Diego, just to give an example. And Aunt Bertha is always going to be there as an option, right? Just as foundational. So keeping that in mind, we're not going to pick it necessarily, just one route for referrals.
So I just have something to add. So this is what we deal with. So we get a lot of referrals from the hospital, but we don't have a fax machine. So we have the social workers call us. And so that's how we get referrals now, which is, obviously not the best process. So, and again, obviously we want to, do this. We want to move forward with this, but I know there's a lot of kinks that need to be worked out. We are at all the tables and all of the meetings, but this is just something that we already have struggled with our local hospitals and getting referrals to us. Our homeless folks have been dropped off on the campus and with no contact with anybody. We've dealt with that in many situations. So now we're in these meetings and having these conversations. So from where I sit, we definitely have a lot of work to do around the communication piece with all the local providers. And I'm in Stanislaus County. And one thing I wanted to add earlier about the HMIS platform is, we have that. We're solid now with our HMIS. We're reporting out. We're doing really well in that arena. When I worked for BHRS, we had this piece of the electronic health record where we could actually look and see if somebody was open to Medi-Cal and what county they were open to. We couldn't see any of their information, obviously no diagnosis. I mean, obviously we could see mental health diagnosis because we worked for behavioral health, but we couldn't see anything that was connected to their Medi-Cal, just if it was active or not. So I don't know if there's some opportunity to have a platform where we, like a need to know, some of the providers can have access to, different parts of the platform. I know for here at the shelter, this is a non-clinical setting. So I don't know if that would, be something that we can look at. But I just wanted to share that.
Thanks so much, Virginia, for sharing that. I think that's really helpful. And I'm wondering if folks either, among your peers or among the implementation team or plan partners have some of the answers to the questions you're raising here.
Yeah, I mean, I think it's fantastic that you guys have a strong and robust relationship with HMIS. There is efforts underway to build a statewide HMIS system that connects all the HMIS systems across California. And there's great hopes that that can be connected to the CIEs, the various data exchanges that currently exist in California, and that some counties are building new exchanges. So that's a great starting point to be in. And it sounds like, are you using HMIS to do case management and for documentation?
Yes, so we had an option. So I think our internal program is WellSky. I don't know if anyone's familiar with that. So we just switched over to that. But what we decided to do was we're tracking services in HMIS, but we decided not to do case notes. I mean, we could always change that. We're doing those in our WellSky. So it's more of the internal piece. But we just made that decision just based on the information that we had. I mean, it can definitely be changed. We were told, though, that your other programs are not able to see that information anyways. So we are tracking services. That's what we're doing. So if we get someone connected to, a housing voucher or mental health services, substance use services, any kind of service, we are tracking those in HMIS, along with our intakes and our exits and our updates and things like that.
That's great. So it sounds like you have a system. I think a big question is, which system is going to be your main system to document in and draw information for reporting to? Ideally, there's an electronic way for billing and for data sharing, but I think everybody up and down the state has recognized we're in the early stages of ramping up ECM and community supports, and that there's a real ramp up build out that's needed. And so you're asking absolutely the right questions. And I think part of it is, as you think about your internal programming, think about what you need to do and how your systems support those workflows and what allows direct exchange of data versus, is this something that you have to extract a file from and maybe manipulate in Excel before sending to the plans?
Yeah, you're talking HMIS now, Lisa. That's what I do. That's what I do every month for 4 programs So we definitely have to do that. We have to extract it and then make a caper and send it off to the state or HUD. So absolutely. I just wanted you guys to kind of see this is our reality and this is where we're at. We want to bring 10 recuperative beds to the table because it's a need here. It's a huge gap in services here. We have our hospitals that need people to come here. Our staff, our organization doesn't have the staffing to assist them to get to that place where they can take care of themselves. We are hiring, I just wrote a grant for 2 LVNs. We were able to get 2 on the other side of the shelter. So that's something that we are hoping happens. So that might be able to support as like a triage in the meantime, but we are definitely growing, and we want to fill the gaps in services. And we have a huge population of our homeless that are in desperate need of this support. They're high utilizations of emergency services. You know, they have a lot of substance use issues. So we definitely need to make this happen some way or the other. We're doing our best to try and fill the gap in the meantime, but it's definitely a huge need for us here. And I mean, we have 393 beds here. So that's a lot of beds. And you know, we recognize this is a need, and so we want to meet that need as best we can.
Well, Virginia, you're asking all the right questions. You're, you know, connecting all the right dots. So it's, you know, I would encourage you to continue doing the same and having ongoing conversations, both with your county and the COC, who can turn on and off certain functions within HMIS. As well as with, you know, your gracious plan partners here who are available and want to have these conversations to really unpack what the needs are and how to create the broader systems that may help support these in the longer run, knowing that there may have to be some short-term solves while those systems are being built. I'm just going to ask the question, you know, I'm curious, like, if folks could like pop into the chat, like what types of, you know, are you using a community referral database like on Bertha's or Unitas or any one of those platforms, 211, that might be useful for everybody to share so that we have a sense of what people are looking at and using, and turn it back over to Sadhna.
That's a great invitation, Lisa. Thank you for that. And so if folks, you know, do have a platform that you're using, would love to see that in chat as you're inviting folks. And thank you so much for your presentation, Lisa. That was all very helpful background as well. I'm going to, while hopefully folks respond in chat, I'm going to share screen and keep us moving. To the next section, and we'll see the chats as they come in, to talk a little bit about a payment for community supports. And for this section, I will turn it over to you, Rishi.
Thank you so much, and Lisa, thanks as well. I think you've made my job really easy. What I'll be saying is largely going to be echoing some of the really great information that Lisa shared, and that each of you have already raised, Virginia, from your question, and some of the information that certainly our plan partners have shared here. So if we go to the next slide here, we thought we'd just go a little bit into the payment considerations, which are a little distinct from some of the delivery and data sharing considerations that we were speaking about a little bit earlier, and review again the standard terms and conditions as our kind of anchor for some just orientation, especially relevant for those who are considering or haven't started even yet the contracting process. We thought this might be really helpful information for you all. And again, as Sadhna mentioned at the top of the call, for those who are further along in contracting, if there's information that you see here that you found to be helpful as part of your process in contracting, if you're a CBO who's further along, please feel free to share information here if you think it's helpful. From the standard DHCS terms and conditions, and again, you can see that chat further up in the link further up in the chat here. What DHCS has shared is that community support providers shall be required to record, generate, and send a claim or an invoice to managed care plans for any community support rendered. It's important to note that if a community support provider is going to submit claims, that those claims should be submitted using specifications based on standards and codes that are that you can learn about by talking to your plan partner. So this is an exact kind of opportunity to follow up if you have questions about standard specifications for your community supports by confirming with your plan partners which specific standards and codes you should be using for the particular type of community support service you're thinking about. if you're not going to be submitting a claim, or if you're unable to submit a claim more specifically to a plan for any community support related services, you can submit invoices. The important thing here is that invoices have to include minimum necessary data elements that DHCS has defined, largely so that DHCS, as well as certainly the plans, are able to use the information in the invoices to be able to track and translate the information from the invoice into now DHCS supported standards. And so, for example, some of those minimum data elements include basic information about the members, information about the type of services that were rendered, and also information about you as a would-be community support provider in order to support appropriate reimbursement by the plans. A key question then, or consideration for you as a community-based organization then, of course, is, well, are you able to provide minimum necessary data elements? And again, in a minute, I'll pause and invite our team, including our plan partners, to kind of weigh in and whatever, if there's questions about minimum data elements or specifications, et cetera, some things that if we can't address at a general level today, please, again, I want to point you back to the really generous offers that the plan partners have made to be able to contact them directly for additional follow-up questions. If we go to the next slide here and think about what it means to be able to submit claims or invoices, another bit of information, of course, is that first, community support providers can't receive payment for provision of community support services that are not authorized. Here's an important point, though. There may be referrals that you receive either from the plan or from ECM providers for types of services that your organization can provide, but that are not authorized under community support right now. And so a really important conversation to have with the plans, including the ones we have on the line today for the work that you're doing in San Joaquin and or Stanislaus, is to get to a shared understanding of what's an authorized service. And then for your own organization, as you're probably already considering, how do you actually make sure you appropriately track those things that are contracted services versus those things that are not contracted services, right? If you have a referral for a type of community support service that you do provide, but isn't considered authorized by the plan. So coming to a shared understanding of what's authorized, and then coming to an understanding on your own about how you're going to be able to track authorized service referrals or requests for services that are for authorized services versus not is important. Community support providers also need to have a system in place, and I think Lisa made this point really, really succinctly here. Have a system in place to accept payment. Obviously, this is a key question for your financial sustainability, and I'm sure you're all thinking about this and have systems in place to a certain degree. The question is that system something that's feasible for you to be able to work with when it comes to the plans? You'll see some of the standard terms and conditions from DHCS indicate that plans are required to pay 90% of all clean claims and invoices within 30 days of receipt, and 99% of clean claims and invoices within 90 days of receipt. Obviously, a key consideration, as you can see on the right, is whether those timeframes make sense for you, especially when you're thinking about your cash flow needs. What are your assumptions about, how much you'll be billing for, and what that means in terms of the potential windows of time here for receipt of payment, and what does that mean in terms of your ability to manage cash flow and your overall expenses. Please note that at the bottom, plans are encouraged by DHCS or required to provide expedited payments for urgent community supports. So for example, recuperative care for an individual who no longer requires hospitalization, but still needs to heal from an injury or illness. Virginia, this might be particularly apropos for you, and other conditions that are considered to be urgent. Again, a conversation with the plans is going to be really important to clarify what process they have in place to provide expedited payments. I heard somebody chime in. Is that
I have a question with
Yeah.
that is when it says expedited payments, what does that mean?
Yeah, that's going to vary, I think, I'll turn to our plan partners to see if I can get a head nod or maybe unmute but I think the answer is that it's going to depend on each plan in terms of what that timeline looks like. But I don't know if Nancy or Cynthia wanted to weigh in on that at a high level.
I think Nancy is off the call, but I have to check with Nancy to see if there's a specific definition of the number of days in which the payment can be made timely. But certainly it would be quicker than the 30 calendar days here that's listed.
Okay, thanks, Nye.
Yeah. Cynthia, did you have anything you wanted to add there on the Health Plan San Joaquin side?
No, definitely. I'd have to confirm with our claims team, but just something that comes to mind. I know, for example, for sobering centers as one of the services, there's certain services that don't require authorization and of course would be treated a little bit differently. So that's the example that comes to mind.
Yeah, thank you, especially for that latter point as well, Cynthia, for that. And I think for all the CBOs, Virginia, yours included, I think that's why the answer of, for the specific community support service that you're thinking about, and that it's really important then to, I think, use the opportunity, if you haven't already, to be able to communicate with some of the plan context specifically, because the answers may vary in terms of eligibility and authorization requirements, as well as what expedited payments are possible. But thank you for that question. And I think it's exactly the type of reason that we wanted to host this gathering, right, to kind of flag that. That's an important consideration. As we go to the next slide. Thanks, Aldana. So a little bit more information and or context for background on payments. For ECM services, plans will be paid by the state, fixed per member per month, the PMPM capitation payments. Those rates are rates that are set between DHCS and the plans. But for community support services, DHCS has provided pricing guidance to the plans to support discussions regarding those rates. And a really important point, and this is me now speaking, we're speaking to the CBOs, and so this is definitely something that is going to be important for you to follow up with plans individually about, because this will vary by plan, including our 2 plans on the line today. While DHCS has provided pricing guidance to the plans, and that guidance is based on a set of research assumptions that DHCS has created. That guidance isn't binding on MCPs or community support providers, or at least not by DHCS. What DHCS has made clear, and this is a language straight from DHCS, the rate agreed to between an MCP plan and a community support provider could fall outside the rate range presented in the pricing guidance that the plan received. If you go to the next slide, what a really important kind of point here is that, again, according to DHCS guidance here, plans will pay contracted community support providers for provision of services based on negotiated rates. And plans are also encouraged by DHCS to tie those payments to community support providers to outcomes, to encourage kind of alignment with quality and health status improvement kind of outcomes of interest. We expect at HealthBegins that more and more plans, perhaps including but not limited to the plans represented today, that more plans across the state are going to be doing this over time as they establish their provider networks and, of course, work directly with each CBO to be able to kind of onboard them into the networks. We expect this is going to continue to evolve over time, especially over the next year to 2 years, in terms of seeing alignment of payments to outcomes. But again, an important question to ask the plans directly in one-on-one conversations or through the emails that have been provided here about that. The takeaway here is that the community support rates that plans offer providers, CBOs such as yourselves, are not standardized across the state and are going to vary therefore across plans, across counties, and are going to depend upon a number of factors like the structure of the program itself that you're offering as a CBO, the staffing ratios that you have, the size of your organization or facility, your location, and certainly your payment model. As you go to the next slide here, we'll unpack over the next couple of slides a little bit more about what we mean by those factors like program structure and staffing ratios and what that means. And I think it'll become clear. There's a reference, and if we can, before the end of today, we'll put the link directly into the chat so it can make it easy for you to be able to open it. This is the DHCS non-binding ILOS pricing guidance document that was put out a couple months ago. And what you'll see there is some helpful information that the CBOs might find helpful in particular about ways in which those variables like program structure and staffing ratios, et cetera, can impact pricing and rates. You'll see an example that DHCS itself actually provided on the right of how caseload variation will impact the kinds of rates that, the costs at least, and the expenses that you might incur as a CBO. So take, for example, a housing navigation coordinator salary of $5,000 per month, and consider that that staff is providing a service to 35 enrollees within a month. If the rate paid for that, based on a payment model that the CBO established with the plan, if the rate paid for that service per person per month has to cover 1/35 of that $5,000 wage, you're looking at a per person per month kind of fee or rate, excuse me, a cost of $143. However, if that worker, if that staff person is able to effectively provide services to only 25 enrollees in that month, the rate paid would need to cover 1/25 of the monthly cost. And so the rate paid would need to be $200. So this is how caseload variation, obviously, as you all, I think, are well familiar with, as you manage your CBOs and your budgets, this is how caseload variation is just one consideration, in addition to payment models and overall program structure and staffing ratios, how these things are important considerations we know that you'll all be taking into account as you consider the rates that you'll need to negotiate or want to negotiate with your plan partners. Again, really want to emphasize the kind of broken record point we've been making today, which is that CBOs are therefore encouraged to reach out directly to the plans to learn about what community support rates might be applicable to you. As you go to the next slide here, some additional context as well for the CBOs to know about, if you don't already. While we were talking about the payments from plans to CBOs and the importance of negotiating, thinking about your rates and then negotiating those rates with the plans, one of the key additional bits of background is the incentive payment. DHCS is establishing plan incentives linked to a lot of the CalAIM reforms, and those incentive payments are going to be there to align with quality and performance improvements overall. The target is to really help to drive change at the managed care plan level, as well as at the provider level, including community support providers. These incentive payments are due to start to come into effect next year, and those payments will be directed towards plans. But DHCS is encouraging plans to partner and share incentive dollars with providers, especially those providers who are able to achieve defined targets of the incentive program. Again, defined targets meaning quality and performance kind of targets. So again, as plans develop quality and performance targets that are aligned with or in response to DHCS guidance, it's worth noting that this may also be a potential source of revenue of ways that are aligned with both CBO's interests, the plan's interests, and overall the DHCS kind of state interests and improving outcomes for Medi-Cal beneficiaries. Again, information to be, questions to be asked of plans as you're considering opportunities. As we go to the next, almost done with my section over here. And again, this is a pro forma for many of you, but a way to kind of summarize some of the considerations here is done really nicely by our friends at Corporation for Supportive Housing, who recently joined us for another a session just last week, actually, we had. It's worth noting that Corporation for Supportive Housing is likely going to be providing technical assistance, especially in the beginning of next year, probably the spring of next year, to a variety of particularly supportive housing providers in the state. And so as we learn more information about when that's online, we'll certainly share that with everybody here. But it's for those who don't already know, Corporation for Supportive Housing is an excellent partner in this space, along with many other partners that we have here, who have a lot of deep experience in helping supportive housing providers understand how to work with Medicaid plans in general across the country. What they've summarized here is that as you're considering negotiations and coming up with, for your conversations with the plans, considering the payment models, whether it's PMPM, per diem, fee for service, unit rates, or even value-based payment models is going to be key. Consider, this is from our friends at CSH in particular, and we at HealthBegins think it's a good recommendation. If you have upfront startup costs that are that you have for being able to do this work for CalAIM, for community support specifically, be sure to estimate those and to bring those up in your conversations with plans. Make sure that it's part of your contracting negotiations in order for you to be able to cover costs, for example, for the first cohort of patients. So as any CBO would be thinking about, what are those upfront costs and what kinds of advances are required for you to be able to reasonably meet those costs. And then as you continue on in conversations with your plan partners, as you're considering this, make sure that you understand what constitutes a clean claim, how and how often those claims need to be submitted, or invoices, if that's the case. Again, how those your rates are going to differ based on the variables I talked about earlier. And then are there other creative funding strategies to braid in funds from other sources as well? The last slide, I think there's one last slide here. We'll include a link to this as well in the chat, especially relevant not for supportive housing providers, but also for other CBOs. One of the things that CSH has shared with us and we want to share with you is a services budget tool. Again, it's designed specifically for supportive housing providers, but we've seen this be a tool that other CBOs, even if you're not a supportive housing provider, might find useful to be able to plug in your own information about staffing ratios and program structure kind of assumptions and be able to use it as a tool to start modeling what your costs might be. And again, we hope that that's a tool that you might find helpful as you're estimating what your rates need to be to cover your costs. So I'll pause there. I think there's time now for any additional questions, or specifically also if there's anybody from my partners at Aurrera or Transform Health or the plan partners that we have on the line as well. If anybody wants to join in to clarify anything I said or to add additional information, please feel free.
Thank you, Rishi. And I know we have just a few minutes left, so while that invitation remains open, also want folks to be able to put into chat or unmute if you've got any kind of burning questions for folks here. And I've included the links that Rishi described during the presentation in the chat, so you should have access to those, the non-binding ILOS pricing guidance, as well as the budget tool from the Corporation for Supportive Housing.
I want to give a shout out. Alex Bajardo, one of our other implementation partners, has also joined the line. So Alex, thank you for joining. I know you're on audio, but thank you for coming in. I see the thumbs up. Appreciate it. Great. Any questions about some of the basic standard terms and conditions and the payment considerations, or even going back to issues that Lisa had brought up earlier? If there's any outstanding questions, it looks like we have a minute or so. All right, with that, Saad, I'll turn it to you.
Yeah, and I'll kind of remind folks of contact information for the plans in your counties. And again, we'll share these out as well as the emails that were shared in the chat with folks in a follow-up email. So just want to reemphasize, all of the points that we've made today, especially in like continuing these conversations with your plan partners moving forward. And feel free to reach out to HealthBegins as well with any questions or feedback. We'll be sending out a survey in that follow-up email. I'll also include it in the chat here for us to really keep improving these TA sessions, make sure that the content is resonating with folks here, and make sure that we're able to help you all as CBOs partner better with your plan partners. We have, as I mentioned at the top, a few other sessions planned up for the next month and a half, or actually now it's just the next couple of weeks. We have a second statewide session that'll be open to all California CBOs, and we'll send an invitation link out to that as that nears. It's going to be on December 16th. And then the regional sessions and a few other tailored TA sessions coming up in the weeks ahead. And so you will receive invitations to those as they are relevant for you. So the November 30th and the December 7th ones in particular. So if you could take a second to please fill out the survey, we would appreciate it. That information is really helpful for us as we move forward, and just really grateful for our presenters' time, both Lisa from Transform Health and Rishi from HealthBegins, as well as all of you for sticking in here. And hope we'll see you again soon. Thank you all for joining us today.